consistently over 5 years in 47 pediatric patients who presented with renal limited full house glomerulopathy was 0.25. The next case is an 11-year-old girl who presented with a 1-month history of prolonged fever, polymorphous rash, aphthous ulcers, mild alopecia, and intermittent arthralgia. Investigation showed the presence of leukopenia, DCT-positive anemia, and a positive ANA, which was homogeneous of more than 1:640. C3 and C4, however, were normal, and anti-double-stranded DNA antibody was negative, but anti-RNP Smith antibody was positive. On admission, she was noted to have a rising serum creatinine, reaching a peak of 88 micromoles per liter from a baseline of 50 previously, despite not being oliguric. She had mild proteinuria of 0.38 grams per day per 1.73 meters squared and mild microscopic hematuria. The kidney biopsy showed mild segmental increase in messenger cells with slightly expanded messenger matrix. The renal cortex showed lymphocytes and plasma cells within an edematous interstitium, with a few tubules displaying lymphocytes within their profiles as shown by the black arrows. The next question here is, the kidney biopsy in this patient is consistent with which histological diagnosis? In this patient, on review of electrolytes at admission, there was normal In this patient, on review of electrolytes at admission, there was normal anion gap hyperchloremic metabolic acidosis with hyperkalemia and a low serum uric acid, suggesting the presence of a tubulopathy. Sometimes tubular interstitial disease may be the only manifestation of lupus nephritis. This possibility should be suspected when a patient with SLE presents with a rising plasma creatinine concentration and a urinalysis that is relatively normal or shows only a few red cells and/or white cells, as well as mild proteinuria. These changes may be accompanied by signs of tubular dysfunction, such as renal tubular acidosis and hypo or hyperkalemia. Autoantibodies directed against the acid-secreting intercalated cells in the collecting tubules may have been responsible for the acid secretory defect in at least some of these patients. So how does the type of lupus nephritis influence options for treatment? The next case is a 14-year-old girl who was admitted for a 3-day history of oliguria and leg swelling. She had facial rash for 1 month associated with lethargy. She appeared pale on examination with generalized edema and blood pressure of 142/88 millimeters mercury. Investigation showed the presence of bicytopenia with severe anemia of 4.3 and platelet count of 99,000. There was hematuria as well as proteinuria, and the blood urea and creatinine were markedly elevated. There was also serological evidence that suggested the presence of SLE, and she required hemodialysis for 3 weeks. Kidney biopsy showed the presence of lupus nephritis class 4 with proliferation of endocapillary cells and cellular crescents, as well as segmental infarct and occasional double contouring of the glomerular basement membrane, and some tubules appeared atrophied. So for question 4, what induction therapy will you opt for this patient? Based on the revised ISN Renal Pathology Society classification for lupus nephritis, this patient had diffuse lupus nephritis class 4 with crescents. Children with class 3 and class 4 lupus nephritis have significant clinical kidney disease such as hypertension, proteinuria, and even kidney failure. In fact, heavy proteinuria is a poor prognostic sign in chronic kidney disease. How did the histological findings influence our choice of induction therapy? The goals of treatment in lupus nephritis is firstly to achieve remission, that is, decrease activity of SLE, restore kidney function, and reduce the degree of proteinuria. This is achieved in the induction phase of treatment. The secondary goal is to prevent progression of chronic kidney disease, and this is achieved by prevention of lupus relapses and reduction of proteinuria, and this occurs in the maintenance phase. IV cyclophosphamide given monthly with or without pulse methylprednisolone, followed by intermittent IV cyclophosphamide or other oral immunosuppressive agents, is widely considered to be the gold standard of therapy for aggressive lupus nephritis. However, a worrying trend is that a significant proportion, up to 30 to 50% of patients with lupus nephritis do not achieve complete remission despite treatment with cyclophosphamide, and this is associated with a significantly increased risk of end-stage kidney failure, relapses, and death. In this study shown here in 86 adult SLE patients with severe lupus nephritis, you can see that the kidney survival rates based on remission is about 94% at 10 years in the remission group as shown by this blue line, compared with 31% in the no remission group. This network meta-analysis of randomized controlled trials for the induction and maintenance treatment of lupus nephritis involved at least 4,000 over adults, adolescents, and children. The primary outcomes of interest for induction therapy were complete remission and all-cause mortality. Other outcomes included end-stage kidney disease, doubling of serum creatinine level, failure to induce remission, and the adverse effects. In maintenance therapy, the primary outcome was relapse after remission. Compared to IV cyclophosphamide, the most effective treatments to induce remission in moderate to high quality evidence were mycophenolate combined with calcineurin inhibitor alone, or mycophenolate alone. In fact, the combination of mycophenolate plus calcineurin inhibitor ranked as the best treatment to induce remission. Again, meta-analysis in adults showed that plasma exchange conferred no additional benefit to the use of pulse IV cytotoxic drugs. Therefore, the main indications for use of plasmapheresis in lupus nephritis remain the concomitant presence of thrombotic microangiopathy or pulmonary hemorrhage, where rapid removal of active mediators such as antibodies or complement components is critical. How about the use of rituximab for induction therapy? In this meta-analysis, two studies compared the addition of rituximab to either mycophenolate or cyclophosphamide versus mycophenolate or rituximab alone. The results showed that addition of rituximab to mycophenolate and steroids was more effective in inducing partial remission than mycophenolate and steroids alone. How about the use of rituximab in children? In the large UK juvenile SLE cohort study, rituximab was given to 31 SLE children with significant proteinuria, and you can see here that a reduction in the degree of albuminuria was seen in post-rituximab therapy, which almost reached significance. Coming to question number 5. Which drug combination has been shown on meta-analysis to be the best for inducing complete remission in lupus nephritis? When considering maintenance therapy to prevent disease relapse, network meta-analysis showed that mycophenolate was among the best for preventing disease relapse during maintenance therapy, while IV cyclophosphamide is among the worst. Therefore, based on the results of all these trials, the current recommendation in adults for the treatment of severe proliferative lupus nephritis is shown in this algorithm. IV cyclophosphamide is used for remission induction, either the NIH high-dose monthly pulses or Euro-Lupus recommendation of 6 low-dose pulses spaced 2 weeks apart, or mycophenolate, followed by remission maintenance with either azathioprine or mycophenolate. A major concern in children with severe lupus nephritis treated with aggressive immunosuppression is the cumulative cyclophosphamide and steroid-related toxicities. These include the problem of infections and infection-related mortality due to over-immunosuppression, as well as the long-term side effects of therapy, especially death on growth in children, osteoporosis, and the question of risk of infertility and malignancy. Although current therapeutic regimens such as this intermittent IV cyclophosphamide treatment for 3 years can result in a 60% decrease in the dosage of prednisolone, however, this has still to be given on a daily basis as shown here. This would still result, therefore, in significant growth retardation. As our ability to treat complications of SLE in children has improved with a resultant decrease in activity over time, however, organ damage due to disease flares as well as complications of therapy tend to accumulate over time in juvenile onset SLE, and this results in an increase in damage scores with time. Therefore, in order to minimize the long-term steroid side effects, in our induction protocol, we use pulse IV methylprednisolone up to 6 doses together with mycophenolate. If the patient is still proteinuric with a proteinuria of greater than 1 gram per day per 1.73 meters squared and the creatinine is normal, we add cyclosporine to the regimen. The prednisolone dose is rapidly tapered, and once the child is in remission with no proteinuria, the dose is changed to alternate day to minimize the steroid side effects. The cyclosporine is taken off and the child is continued on mycophenolate maintenance therapy. The main difference in our induction protocol with that of the adult protocols is the use of IV methylprednisolone pulse therapy instead of high-dose oral prednisolone. IV methylprednisolone has been shown to kill plasmacytoid dendritic cells that make the type 1 interferons, which are the major driver of lupus. In addition, dendritic cells regenerate in a week, implying that repeat pulsing may be useful in inducing remission. In our study, children with the severe proliferative forms of lupus nephritis did well with the combination of IV methylprednisolone pulse, mycophenolate, and cyclosporine. There was normalization of the serum complement as shown in this graph, significant reduction in proteinuria as well as hematuria, and all of them also had improvement in the SLE disease activity index. We went on to look at the long-term outcomes in this cohort of children. The median duration of follow-up was 9.2 years, and all children achieved complete remission within 24 months of starting treatment. With long-term mycophenolate maintenance therapy, the cumulative relapse-free survival at 10 years was 73.3%. And the main problem that we had was that the patients sometimes became non-adherent to medications because of the twice-daily dosing. Use of this form of multi-targeted therapy in our cohort of children has allowed better increase in height standard deviation scores compared to the cyclophosphamide azathioprine group. The next case is a 9-year-old boy who presented with nephritic nephrotic syndrome for 1 week. Investigations then revealed gross hematuria and pyuria with a direct Coombs test positive hemolytic anemia, leukocytosis, and normal platelet count. His serum complements were low, and he had elevated anti-double-stranded DNA antibodies as well as a positive anti-nuclear antibody titer. Kidney biopsy confirmed the presence of class 4 lupus nephritis. He went into complete remission after treatment with 6 monthly pulses of methylprednisolone, mycophenolate, and tacrolimus. He remained well on prednisolone and mycophenolate and was able to taper off the prednisolone 5 years later, maintaining on mycophenolate monotherapy. However, he had relapse of nephrotic syndrome at the age of 17 years. As shown in this table, during his first relapse, other parameters of lupus activity, such as C3 and C4, were normal. His proteinuria responded rapidly within a week to initiation of pulse methylprednisolone therapy. However, he relapsed after a month and again responded rapidly within a week to initiation of high-dose steroids. He had yet another relapse 3 months later and again responded rapidly within a week. A review of the electron microscopy done at the first relapse showed extensive, about 50 to 80% of podocyte food process effacement with focal microvillus transformation of podocyte cytoplasm. Coming to question 6. Based on the EM findings, what is the most likely cause of the nephrotic syndrome in this child? This child showed features of lupus podocytopathy. In this large cohort study of 50 adult Chinese lupus patients who were identified as lupus podocytopathy, kidney biopsy showed the presence of minimal change in 26%, mesangial proliferation in 56%, and FSGS in 18%. 94% of patients achieved remission after immunosuppressive therapy for a median time of 4 weeks. Therefore, there is a proposal to recognize lupus podocytopathy as a distinct entity with the following criteria. Firstly, SLE must be diagnosed by the ACR criteria with the presence of a full nephrotic syndrome. Light microscopy should show either normal glomeruli or FSGS only. Immunofluorescence microscopy should show either no deposits or deposits confined to the mesangium. And on electron microscopy, there should be diffuse and severe food process effacement, typically more than 70%, with either no deposits or deposits confined to the mesangium. For our patient, since we diagnosed him as having lupus podocytopathy, we started him on cyclosporine to maintain remission and gave him a dose of rituximab as well in order to prevent further relapses of the nephrotic syndrome. So finally, I would like to leave you with the following take-home messages. SLE in children tends to be more acute and severe at onset and to have a higher rate of major organ involvement, especially lupus nephritis. Kidney biopsy is useful to confirm the type of lupus nephritis and stage the disease in order to decide on treatment strategy. Treatment of lupus nephritis can be divided into an induction phase with the goal of achieving renal remission and maintenance phase with the goal of prevention of lupus relapses and reduction of proteinuria. Network meta-analysis showed that the combination of mycophenolate plus calcineurin inhibitor ranked as the best treatment to induce remission. Mycophenolate was among the best for preventing disease relapse during maintenance therapy, while IV cyclophosphamide was amongst the worst. Meta-analysis showed that plasmapheresis conferred no additional benefit to standard therapy. and the addition of rituximab to mycophenolate and steroids was more effective in inducing partial remission than mycophenolate and steroids alone. And finally, we should remember that therapy should be individualized as not one size fits all. Thank you very much.
Okay, so thank you, Prof, for your interesting talk. So now we know lupus doesn't just cause proliferative GN and membranous, it can also cause lupus podocytopathy and even TIN. Okay, so there are quite a few questions, Prof. So maybe I'll group them first with regards to diagnosis and then treatment. So the first question is on diagnosis. So if let's say there's a child with systemic inflammatory disease with Raynaud syndrome and multiple positive ENAs, so if, I presume there was a biopsy done and it showed membranous nephropathy, and there was also negative immunofluorescence C1q and C3. So would that likely decrease the likelihood of SLE nephritis?
So I think we have to be sure that, first of all, our immunostaining was good enough, because in order to make the diagnosis, you need to have good immunostaining. And sometimes they use histochemistry, you might get false negative if the background is very high. So I would talk to the pathologist to make sure about that. Then secondly, we do have a problem sometimes when you see that, because you could have mixed connective tissue disease. Even though renal involvement is very rare in mixed connective tissue disease, it's still possible. So that becomes your differential diagnosis given the very positive X-ray nuclear antigens that you've seen.
Okay.
So I would keep my options open for that diagnosis and consider treating as such. Yeah.
Okay, so moving on now to quite a number of questions on the treatment. So first, regarding the cyclophosphamide pulse. So if only partial remission is achieved after 6 pulses of the IV cyclophosphamide, then what would you recommend the plan of treatment?
I think if the patient has already received high-dose steroids, especially methylprednisolone, together with the IV cyclophosphamide, and he's still not in remission, I think what I might choose for this particular patient, again, as I said, I would individualize it. I might actually consider giving him rituximab followed by mycophenolate, and then if the proteinuria is still heavy, consider adding a calcineurin inhibitor at that point. But I will not repeat the cyclophosphamide, because after 6 pulses, I think it's got more than enough cyclophosphamide, and it can become a problem, and we know that he's not exactly that responsive.
Okay, thanks, Prof. So the next few questions will be regarding the use of CNI during the induction phase of lupus treatment. So let's say if the patient has lupus class 4 and dialysis dependent initially, will you give CNI during the induction treatment?
Okay, so I think this is very important that we get this correct, is that I will not use a calcineurin inhibitor as long as the creatinine is raised. In other words, if there's decreased renal function, I will avoid the calcineurin inhibitor. So in that position, and I've had patients like that who have got rapidly progressive GN with crescents, dialysis dependent, we use pulse methylprednisolone together with mycophenolate. And after, probably this takes about 2-3 months sometimes. Once the creatinine is normalized, if the proteinuria is still there, then I add the calcineurin inhibitor. So the caveat is that the creatinine must be normal before you add the calcineurin inhibitor. Then in that case, the patient actually got completely well, complete remission subsequently. We mustn't use the calcineurin inhibitor because it's nephrotoxic during that acute phase, you see. So I would not use it at that point.
Okay, so if once we decide to give calcineurin inhibitor, so how long should we give? What are the markers we decide when this patient can stop the calcineurin inhibitor?
Okay, so the aim of giving the calcineurin inhibitor is to get rid of the proteinuria. So that is the first thing we must make sure happens before we think of discontinuing it. Then the second aim is to bring down the steroid dose, because the whole idea of the multi-targeted therapy is that we are going to do the same thing as high-dose continuous steroid therapy can achieve, except that you'll be very toxic. Because after you give 6 months of high-dose steroid therapy for the very difficult lupus patients, the patient will be steroid toxic. So the idea of having this multi-targeted therapy is that we can then taper the prednisolone down. Once they've gone into complete remission in terms of no more proteinuria, no more hematuria, I taper down the prednisolone to an alternate day dose if possible, and if the patient is still well, even to the point of taking it off. So they're either on low dose alternate day, or we take off the steroids, and if the patient still remains well, we stop the calcineurin inhibitor and maintain our mycophenolate alone. Because the long term, you don't need the calcineurin inhibitor. Once the proteinuria has gone, the mycophenolate is meant to hold the disease activity of the SLE. So that's what we're aiming, is to hold the disease activity.
Okay, so the next few questions regards to the maintenance phase of treatment. So one question is regarding the dosage of MMF. Is there a difference between the dose given in induction and the maintenance phase?
No, for me, I would give the same dose in the induction and the maintenance phase. But once the patient is very well for at least 2 years, and I'm sure there's no more evidence of activity, and you are really considering whether it's time to taper off the immunosuppression. So usually we say 5 years of no evidence of disease, maybe we can consider tapering off. Then I'll begin to reduce the mycophenolate dose. So I'm very careful about this, because as the child grows up, they go into puberty, and that's when the disease activates again. So I wouldn't want to change the dose. In fact, sometimes I move the dose up as the child grows according to its body surface area, because you will notice that for the girls, especially as they grow older at puberty, that's the time when they relapse again. So we must be careful about dropping the dose too low. We are using monotherapy MMF. So we had to maintain the therapeutic dose, and make sure that they stay in remission. And if they're really in remission, then you want to cut the dose. I will do it gently, because I've seen patients, as you cut the dose, the C3 begins to start falling. So you cannot cut, you have to maintain it up there. So basically, I'm using MMF in place of prednisolone that you would normally use on a daily basis to maintain lupus patients in remission. I mean, it's well known when you give lupus patients prednisolone alone alternate day, they actually flare on the alternate days. So that's why you need a daily immunosuppression for these patients.
Okay, Prof, what about the steroid? What's your pace of weaning the steroids during the maintenance phase?
Yeah, so we will wean it down, and usually I go on a monthly basis. I think that's safe. I don't think we want to go rapidly down, because, as I said, lupus is a very chronic and very active or aggressive autoimmune disease, you see. So we cannot just cut the steroids very fast, so I'll cut it down by the month. But having said that, we don't go on very high dose daily oral, because we give them pulse IV methylprednisolone. And after the pulse, we actually give them between 0.5 to 1 milligram per kilo per dose for the maintenance on a daily basis. And I usually never go above 30 milligrams. So for the bigger children, we give 0.5 milligrams per kilogram per dose on a daily basis. For the smaller children under 30 kilograms, we maybe give 1 milligram per kilogram. So the idea is that we don't want to give 60 milligrams to anybody whom we have pulse on a monthly basis. So the idea of doing the pulse therapy also is to give them lower maintenance steroid doses, so that they have really very, I would say, a low incidence of steroid side effects, you see. Okay. So I'll go slow on the cutting down. So since we already start at somewhere like 30 or 20, you can cut by 5 milligrams every month, you see. And you're in a nice, comfortable range where the child is not steroid toxic.
So at what point during the maintenance phase will you consider stopping the steroids? I
usually use the serological markers to help me. They have no clinical symptoms anymore. In other words, disease activity clinically seems to be 0. And then the C3s are normalized. I don't use the dsDNA because that can be high, and yet the child is very well. So the complements are normalized. Then I consider tapering off the steroids even.
Okay. All right. So, Prof, for the patient with the class 4 lupus nephritis, the crescents on the lupus biopsy, so why you choose to induce with metapred and not the pulse cyclophosphamide?
Yeah, because our idea really, in our protocol, we find that when you use pulse IV cyclophosphamide, there's always a higher incidence of infection. Okay, and when there's renal failure, it's even worse, you see. So in our protocol, we use mycophenolate in place of IV cyclophosphamide. And with the pulse IV methylprednisolone, actually it's very powerful. It's probably just as good as a pulse IV cyclophosphamide, if not better in terms of side effect profile. And the mycophenolate is short acting, and it's a very good anti-proliferative agent also. So it acts on both the T cells and the B cells. So with this combination, okay, we find that we can treat a lot of patients with very active lupus, including CNS lupus. They respond very well to this combination without the need for IV cyclophosphamide. In fact, our program has stopped using IV cyclophosphamide since 1995. And I would say that our lupus patients do quite well with this form of induction therapy.
Okay, so there are still more questions, but I thought we'll just end with this last question, which I think a lot of us want to know. What is actually refractory lupus nephritis, Prof?
Now, refractory lupus nephritis are those that after doing everything that we have done, they still cannot get into remission and they're very active. And there are a small percentage of patients who are like this and they are really quite difficult. So in that group, you might want to try rituximab. Some people have even tried plasmapheresis, and we even move on to consider the newer drugs like obinutuzumab and tocilizumab even has been proposed. And Adalimumab has been used, but it's not as proven or as good as probably the anti-CD20 antibodies. So if I have to use a different anti-CD20 antibody, I'll probably choose obinutuzumab for those patients to see whether it works or not. But having said that, it then increases your adverse effect profile as well.
Okay. All right. So thank you, Prof. I think in the interest of time, we'll end this Q&A session. Okay, back to you, David.
So much, Prof. Yap and Dr. Perry. I think that was a highly useful session, and definitely lupus nephritis is something we all manage commonly and something some of us struggle with at times with difficult patients. So we've now reached the end of this morning's session, and I hope it has been as thought-provoking for you as it has been for me. We'll now take a quick break and resume back at Singapore time 2:15 p.m. That's 15 minutes past 2. This current webinar session will end after 20 minutes from now to give you a chance to go through some of the typed responses to the questions and answers that our speakers have kindly done up for us. This can be found under the Q&A tab. After that, the webinar session will end after 20 minutes. And then at the end of the break, roughly 5 to 10 minutes before the start time, please log back in using the same link you used this morning. So I'll see you soon.